Ladies and gentlemen, I will now switch to English in order to welcome Mr. Henri Bendelac. I hope I pronounced it correctly. He is the European Director of Medical and Scientific Affairs of Abbott Diagnostics. As you may have already suspected, he is going to present to us the latest developments about testing of coronavirus and especially rapid testing. So, Mr. Bendelac, hello from Athens.
Hello from France and from Europe.
Your floor is yours for 15 minutes, and then we will have some time for Q&A. Thank you.
Thank you, and thank you so much for the invitation. So just to quickly introduce myself, so as you said, my name is Henri Bendelac. I have a medical background. I work a couple of years as an emergency physician in France, and then I joined the industry. Presently I'm working as medical director for Europe in our rapid diagnosis division in Abbott. So if I can have the slides, please. Thank you so much. So next slide, first slide in fact, please. So just I will not in fact introduce and describe Abbott, but just to emphasize the fact that we are a global provider, and we want to provide not only a wide range of tests and solutions, but as well to discuss with our partners, customers, how we can implement a global solution which include a testing strategy, well, basically not only products. And in this presentation, I will mainly focus on a couple, not on product description basically, but on a couple of concerns which are important from my point of view when defining a testing strategy and choosing the relevant product. So next slide, please. Thank you. So you can see on this slide we have a very global range of product. What I wanted to emphasize on this slide is the fact that we can define two family of testing solutions. On the right slide, right part of the slide, you want to see all the solution we have for the central lab, centralized testing. The architect, for example, as far as I know, the architect is pretty well known in Greece, and we have the M2000 for molecular testing, our new range product, Alinity, and so on. So all this is dedicated to centralized testing, and of course the volume and the quality of the result are really the key point there. And we have the second family of product for decentralized testing. So you can say decentralized point of care, whatever. It's always the same idea to test outside of the lab. And we have offer and products for all the steps of the diagnosis, acute diagnosis with a particularly molecular solution. We are about to deliver on the market a new antigen test, and we have as well a point of care solution for antibody testing. And of course, the specificity of this family is to be used and delivered not only in hospitals, but as well in the community, so GP offices, pharmacy offices, drive-in, who has not, and everywhere that it's not so easy to obtain central lab result, or where turnaround time is key. So next slide, please. As I told, my key point is really the point I would like to emphasize, and I think that it's important to consider when defining a testing strategy two things. The first one is the kinetic of the biomarkers, because it's easy to claim, as we do, that we have very good tests with high sensitivity and high specificity, but at least it's important to define the kinetic of our what we want to diagnose. And in the case of COVID-19, it's particularly important because, you know, usually we define precisely the targets, the performance, and so on, and then we come to the market. In this very specific pandemic, we are all doing the two in parallel. I mean, we don't learn then test, we learn managing testing in the different markets. So it's a very specific and brand new situation. This is a global picture of the don't know if it's this slide. You have the global kinetic of
Sorry, Mr. Bendelac, we have some connection problems. I don't know if you can hear me.
Yes, I can hear you and I see you. Can you hear me and see me as well?
Okay. The problem is okay. Okay, you can continue.
Thank you so much. So I was explaining that it's important to know. You see that global is a kinetic of biomarker for classical infection. So as you know, we have the acute phase with the presence of the virus, therefore virus RNA. And we have in parallel the antigen. So both are used to detect to diagnose the virus during the acute phase. The difference is first that with RNA, with PCR and molecular testing, you search the RNA of the virus. With antigen testing, you search the proteins, antigen from the virus. And secondly, the key difference is that in molecular testing, there is an amplification phase. In antigen, we detect directly the antigen. So, of course, it's one of the reasons which explain the key success of PCR. And in the second step, recovery phase, but not only, we want to consider the kinetic of antibodies. And again, as I said, usually those kinetics are extremely well known before to come to the market with a test. For COVID-19, it's not yet the case. You know, we have a day after day new publication, new articles, new insight from literature in order to know how what is this kinetic. If you want to go to next slide, please. So this slide is coming from literature. So it was publications, an article published in JAMA. It's a global review of literature. And you want to see on this that we have a couple of interesting information about the kinetic of the SARS-CoV-2 and the different biomarkers. The first point you want in red, you want to see the presence of the virus itself, so which is possible to diagnose even if it's not our first step. And in blue, you want to see that the PCR positive result have a pretty long duration. If we compare to influenza, to flu, for example, we know that we have a 100% PCR positive for flu approximately during 3 days after symptom onset. And for all the strains of influenza or flu, all markers, all strains come back to 0 after 10 days. So it means you have PCR positive maximum during the 10 first day and mainly during the 3 first days. Therefore, during the acute phase of the infection. You want to see on this slide, it's interesting to see that the PCR is still positive after 3 or 4 weeks. And therefore, no, I'm still on the previous slide, please. If you can switch back to the previous slide. No? Yes, thank you. So you want to see that the PCR can be positive, and so it's going to keep this in mind when we analyze results from literature. Because if you define, for example, an analysis group or a comparison group with a PCR positive, it's not sure at all if you don't have the date of infection and the time from symptom onset that you will have a group which is really at the acute phase. And you can see, for example, that we can have PCR positive even if the antibodies are already raised. And moreover, yet you can see in this graph as well that IgG and IgM start more or less at the same time, which is unusual because, for most of the bacteria and virus, IgM raise before IgG. So this is a point we have to consider. And last but not least, you want to see on these figures that we have nothing about antigen because it's not yet well known. And it's, of course, for us and for everybody, I think a key point, we need to improve our knowledge in terms of antigen kinetic before to come with a clear serology testing. And again, even if we have a very good test in terms of performance and on analytical sensitivity and specificity. Next slide, please. So this is the second point I would like to emphasize because I'm always surprised by the fact that most of the articles and most of some cases recommendation, including from health authorities, from my point of view, underestimate the place of prevalence. So this is a basic calculation just to illustrate my point. This is an hypothetic test. You want to see that with a low... can you come back, please, to... No, sorry, this is the right slide, excuse me. So if we have a low prevalence, so this value of 5% is the average prevalence of COVID-19 in Europe, but as far as I know, in Greece, the prevalence is even lower, 1 to 2%, if my data is correct. And of course, with a pretty good test, 98% sensitivity specificity, we see that predictive positive value, in fact, the capacity to diagnose positive patients not so good, even with these high numbers. If you increase the specificity only by 1%, and even if the sensitivity decreased by 8%, well, you have a much better a positive predictive value, and you have less false positive when you analyze a population and you want to identify positive patients. And of course, if you choose a lower sensitivity, even if lower specificity, even if the sensitivity is excellent, you see the predictive value, you have more false positive than true positive. So this test is definitively a nightmare. But in all cases, it's the same test. If you want to switch to next slide. So if I change this, so I look at this second situation, the prevalence is 40%. As you see, for the same test, the number are definitively different. And for example, with a high sensitivity, you want to diagnose most of the positive patient, and you have a very few number of negative results. So in all cases, it's exactly the same case, but it's highly correlated to the strategy, the testing strategy, and the inclusion strategy. And for example, it explains why it's perhaps not so interesting to do global testing with all the population when the prevalence is particularly low, even if, of course, on a business point of view, it would be very interesting for company to sell a lot of tests. But on a scientific and health strategy point of view, it's not be so relevant. And even if you have the same test, my last point about prevalence, it will have an impact on testing strategy. Because, for example, if you take all people directly with flu syndrome or suspected flu syndrome without a first evaluation of a healthcare professional or a physician, the prevalence will decrease, because even if the clinical sensitivity is not so good, and of course, as the industry, we claim that this is not so good, the clinical sensitivity, to please use test. Even if it's 50%, for example, it's not good, but it means that you will have to test a population in the emergency department, for example, where the prevalence will be 50%. And in this case, you will have much more result, much better performance, even with the same test, that if you directly test with the same test the global population. An illustration of that, if you want to, next slide, please. So this is real data from articles already published. The left part of the slide is an illustration of that. You see that we choose to have a very high cutoff, high threshold, because the target for this test, it's an antibody test, was to obtain an excellent specificity up to 100%, without losing too much on sensitivity. But you can see there that depending on the threshold that our research and development department will choose, we can slightly change the sensitivity and specificity, and it's always an important discussion, an important analysis to define this. And on the right part of the slides, coming from another article already published, you want to see how is important the place of the time from symptom onset, because, for example, under 13 days, you see that the sensitivity is less than 50%. And after 14 days, the sensitivity is double. So when you have an insufficient knowledge, when you have uncertainty about the date of symptom onset, but I don't know, for example, a physician will claim, I don't know, between 10 or 15 days, you want to see that it's important to clarify, because the sensitivities for the performance of the test can be the double only because of that. So again, just to illustrate how important is the place of the knowledge of the kinetic of biomarker before to define any testing strategy. Next slide, please. Have to run. So this is an illustration of that. You want to see that in this presentation, I cannot go, unfortunately, into many details, but we are in a situation. You see the left part with initial patient assessment. So we assume that we are, for example, emergency department, GP office, and the patient is seen by a healthcare professional. So the prevalence automatically will increase because we will have the first level of clinical suspicion before to choose. And then we have some knowledge about symptom onset and so on. So thanks to that, it's possible to define a very precise strategy testing regarding if we think that we are in the middle of the acute phase, yes or no. Our claim, of course, is to offer the product. Abbott claim is to offer the product for all part of this decision tree, but it doesn't mean that you want to use all tests everywhere and in every situation. If you want to go to next slide, please. So it's more or less exactly the same, but the difference is that in the situation you want to do, for example, global testing, or you want to test workers in a dedicated industry because for any reason this industry is important for your country, you have no initial patient assessment. Therefore, you don't have a lot of data. You have a suspicion, perhaps an idea about the exposure, but no more infections. Therefore, as I explained previously, the prevalence will be completely different, and the testing strategies should be different depending on the situation. I have no time to comment those two algorithms and those two trees, which are the key part of my presentation, but just to emphasize the fact that they're really based on scientific data, published data, and key guidelines, and that we well, it's not only a view or from our imagination, but it's really based on recent data. And of course, we improve, or we try to improve this decision tree day after day. I don't want to say, of course, that it's a place of the industry to define the testing strategies. This is, of course, the role of a regulatory agency, healthcare institution, and government. But we want to be partners and to provide relevant solution and discuss with you relevant strategy. So then last slide. Oops, I have 10 seconds, just will be my conclusion. So as I said, what we really wanted to provide an effective answer to the question you have. We have a wide range of technology and of tests. We have pretty good performance, and we are high claim on this on this solution. But again, the key point is that having good tests is one thing, but the key point is to have a good testing strategy, good clinical pathway, nice patient workflow as well. And I hope that I was able to explain during this 10 minutes why it's important to focus on this point and not only basically on the performance of the test. Thank you so much for your attention.
Thank you very much for your presentation. And as you said, Greece is a country that has very low prevalence of COVID-19, something between 1 and 2%, you were right. So the testing strategy in this country should be much more different than in Spain or in northern Italy, isn't so?
Yeah, probably. And I would say that I know the situation in Spain. I would say as well that probably the strategy in the region of Madrid would be different than the rest of Spain, because as you know, Madrid was really the center of the pandemic in Spain, and they suffer a lot of contamination and a lot of deaths in the region of Madrid. So I fully agree with you. This is part of the point I wanted to emphasize, that the knowledge of the local situation is definitively extremely important. I mean, from my point of view, and even if it's a point which is against
your interest,
opportunity, I would not suggest for Greece to manage a global testing strategy for the global population.
So there are many antibody tests in the market, but the problem is reliability. It is clear that globally we desperately need more reliable tests. So what can Abbott offer in the next 2 or 3 months and so in this field?
What we offer is the fact that, as I said, we have a global range of solutions, and we have more than 20 studies managed in parallel in different countries by different external institutions. We have, of course, our internal study, and it's important for us first to prove that we have good product, and in parallel, because we need data if we want basically to improve our product. So yes, we developed. Just to give you a quick example, we focus today, we are coming to the market with a self-test. We really focus on IgG. because if you see very recent literature and very recent studies with our product, but even with other product, the kinetic of IgM is not so clear than for other infections. And it's definitively difficult today to clearly define the place of the IgM. So I say that even that our test, our point of care test, detect separately IgM and IgG, and it's nice to have it. And I'm really happy to collect data about the IgM. But in terms of testing strategy, I would focus more on IgG. And as I show you in a previous slide, you see that we have today very precise data about the kinetic 0 to 3 days, 3 to 8 days, and 8 to 13 days. You see that the difference in sensitivity was really extremely important. And this is for us a strong knowledge. We invest a lot in order to improve this knowledge. We have a couple of studies in United Kingdom, Spain, France, Germany, and Brazil, Argentina, other parts in the world. Japan clearly have the better knowledge in order to come with a better product. In terms of analytical sensitivity and specificity, of course, because we start the evaluation on the bench, but even in terms of clinical sensitivity and specificity, as I said, I have a medical background. I'm not a biologist, so for me, clinical sensitivity and specificity are really extremely important in a testing strategy. It's not because the test is very good in the lab. If you want to manage a testing strategy, I don't know, in the parking of a large factory because you want to evaluate the worker of those factory, well, you need something. You want to be sure about your test, your clinical sensitivity and specificity on, for example, capillary blood, and not only to know with on plasma your test is excellent on a bench.
So I have a question from overseas. Are the IgG tests specific for SARS-CoV-2 or for coronavirus family in general?
They are. This is a pretty good question, and this is a challenging question. In fact, yes, they are specific for SARS-CoV-2, and we are working a lot on this because usually when we evaluate our test, the first question is to demonstrate that we have a good sensitivity specificity. That's fine. Then the second question is to provide a precise analysis of the cross-reactivity. And usually for other tests, it's easy because we have a lot of samples and we have a lot of partners all over the world who own sample banks. So for example, we perfectly know that we don't have cross-reactivity with influenza, with a lot of other viruses and bacteria. The question for the coronavirus family is extremely tricky because, as you know, this family of virus is supposed to not be pathogen. Okay, the coronavirus officially is not a pathogenic, and before SARS-CoV-2, and except very local situation like the SARS-CoV-1 in Middle Earth a couple of years ago, nobody took care of coronavirus before the last months, sorry. So it means that nobody owned sample bank for the various sub-strain of the coronavirus family. And it's really an important point for us, and we are working more and more on that because historically we did not have the sample bank, and moreover, we don't know the prevalence of other coronavirus because they are not pathogen. You take a dedicated coronavirus, you don't really know what is the prevalence of this dedicated coronavirus in the global population. So yes, we did a lot of work in order to be sure that we will not face cross-reactivity with our test.
So, Mr. Bendelac, thank you very much.
Thank you again for your attention.
I hope to have some good news from your company in the next few months. Thank you very much.
I would be happy to do so. Thanks to you, and thanks for your attention.
Bye.